Hi everyone, welcome to the second video in the unit on immune disorders and vaccinations. In this video, we're going to talk about what hypersensitivity disorders are, which are also known as allergies. There's four main types, and we're going to go over the difference in the mechanism behind the four different types of hypersensitivities. So hypersensitivities are described as an overreaction by the immune system. So this is an undesired immune response to an antigen that is foreign. So the immune system is doing its job, it's responding to something foreign, but it's a non-threatening antigen, it's not a pathogen, it's really not something we want the immune system responding to. And so there are four main types. The first type is called type 1, which is mediated by IgE. And this is really what we think of when we think of allergies. Type 2 is called antibody-mediated cytotoxicity. Type 3 is soluble antibody-antigen complexes. And type 4 is called delayed cell-mediated hypersensitivity. So we're going to walk through the four different types and see the difference between them. So type 1 hypersensitivities are what we consider your standard allergies. So if you're allergic to grass or pollen, if you're allergic to pet dander, or if you've got food allergies like you're allergic to peanuts, those are all type 1 hypersensitivities. What happens in the body is this is a two-step process. First, you have to have the initial exposure to the allergen to produce IgE. And so the key with this is going to be that it's mediated by that IgE antibody. And if you remember from the immune system section, IgE is typically used against helminth infections. It doesn't have a large role in the body. And so this is really the body producing IgE when it's not really supposed to. So this initial exposure is going to happen just like it would for any immune system response, where we've got our antigen. It's being phagocytosed by our antigen presenting cell. So say this is a dendritic cell that's taking the antigen in. It's processing it, and it's going to put it out on that MHC class 2. Remember, your class 2 is then going to interact with the T cell receptor of a helper T cell. And in this case, that helper T cell is going to differentiate into a Th2 response, which means it will interact with a B cell. And remember, the B cell would have already interacted with the antigen, presented it out on its MHC2. So now we have these B cells here that are going through clonal selection, and they've been activated. But they're not going to produce antibody the way they normally do. Instead, what they're doing is they're producing a whole bunch of IgE. This is important because what IgE does is it's going to bind to your mast cells. So here we've got a mast cell, and notice that it's bound with the Y ends pointing out from the cell. What this means is that the mast cell itself had a receptor on the surface for the Fc portion of the IgE. And so we bound to the constant region of the antibody, and that leaves the Y shapes out here to bind the antigen. And so this is what happens in that first step. Now what you have circulating in the body are these mast cells that are primed. We call them sensitized. They have this antigen binding to the surface, but they haven't done anything yet. However, now, if we have a secondary exposure to that allergen, the allergen comes into the body, these IgE bound to the surface recognize the antigen and bind to it, and that binding causes mast cells to degranulate. If you remember, mast cells have histamine in them and vasoactive factors, and so it's that histamine and the vasoactive factors that really lead to the symptoms of your allergy. These can be minor symptoms, things like hay fever that might give you a runny nose and give you some congestion, or it could be a systemic reaction, and those vasoactive factors lead to a huge drop in blood pressure, and that's really what anaphylaxis is. Either way, it's all because you produced IgE in response to the antigen at some time previous to your second exposure. Type 2 hypersensitivities are also antibody-mediated, but in this case, it's typically IgM that's controlling the hypersensitivity as opposed to type 1 that was IgE. So this is involving antibody-mediated cell destruction. If you remember, when antibodies bind to surfaces, that activates the classical complement pathway. And once that classical complement pathway is activated, complement proteins will bind to the surface of whatever that antibody is bound to, poke holes in the membrane, and lyse it. So if antibodies bind to the surface of our own cells, that's going to cause a problem because complement's going to be activated, it's going to bind to our own cell surfaces, and that's going to destroy them. That can happen to any cell type that has an autoantibody that is now binding to the self cells. One example that we see is involving your blood donations. Now, most people should have a general sense that when you look at your blood types, if you are an A blood type, it's because you have A sugars on your surface. If you are a B blood type, you've got B sugars. And if you're an AB blood type, you have both. If you're an O blood type, you've got no sugars out here on the surface of the red blood cell. Those sugars can be antigens. So if you're an A blood type, A is self, but B is foreign, and so you'll have antibodies that could attack the B blood. Opposite for B, B is self, which means you would have anti-A antibodies that could attack the A type. If you're an AB blood type, you don't make any antibodies against them because both A and B are self. And if you're an O blood type, you have both of them, and you would attack all three of these blood types. If that happens, so for example, in this example here, we had a type A donor and a type B recipient. And so the A blood was given to somebody with B blood. Remember, B blood had those anti-A antibodies. They bind to the surface. When they bind to that surface, that activates your complement cascade and causes the lysis of all of those red blood cells. Now, if you just went through a blood transfusion, you needed those red blood cells. Lysing them all into the body is going to be problematic, and this is why we need to match blood types when you do blood transfusions. Type 3 hypersensitivity reactions are very similar to type 2 in that they involve antibodies and complement, but the key difference here is that these are antibodies that are binding to soluble antigen, so not antigen on the surface of something. This becomes a problem because it forms these insoluble complexes. So you can see here we had some individual antibody, and this can happen with both IgG or IgM. It's binding to the antigen, but remember we can have multiple Ys binding to multiple antigens, and so it forms these complexes. If these complexes are not phagocytized and removed, they end up getting stuck in the tissues. And so when that happens, you can see this complex here, they got trapped in this tissue. We have a reaction to that. That triggers complement. It also triggers your inflammatory reactions because remember C5a is going to act as a recruiter, bringing in things like your neutrophils. Neutrophils degranulate and that starts to destroy the tissue. C3b also binds, and again we get our complement that's going to be destroying the tissue. This happens in a lot of our tissues, so we can see this especially in joints and skin, having these types of problems. In fact, rheumatoid arthritis is a good example of a type 3 hypersensitivity. Type 4 hypersensitivities are also called delayed type hypersensitivities, and these are the only ones that don't deal with antibodies. So instead, these are going to involve your phagocytic cells activating your T cells as opposed to your B cells. Similar to your type 1 hypersensitivity though, you have to have a first exposure to sensitize the immune cells, and then on a second exposure, you get a strong immune response. A good example of this is what we call contact dermatitis, which are things like poison ivy, poison oak, or if you have latex allergies, things that you come into contact with on your skin. What happens here is that there's an antigen from whatever it is that you're allergic to. So in this case, some of the sap from poison ivy, that gets into the skin, but these would typically be haptens, so they're tiny. What happens is they actually get in, they bind to our own self proteins, which makes them bigger, and it also makes self no longer look the same. When that happens, it becomes phagocytized by the dendritic cell, presented out here to your helper T cell, which is going to divide and develop into memory cells. Now, if you respond to that same antigen again, you've got these memory helper cells, which are going to become activated. They produce a whole bunch of cytokines, and what those cytokines do is it describes a Th1 or a cytotoxic T cell response. So we activate our cytotoxic T cells, they come over here, the cells that had that hapten associated with them are now going to be destroyed, and so the cytotoxic T cells are killing these cells, and the reason you get the lesion is because that's all the fluid from the inflammatory response that's going to be happening. This table here is just here for a good way to help you study the different types of your hypersensitivities and kind of what are some of the key factors and differences between them. If anyone has had allergic responses, you might recognize that they're a little bit hard to diagnose. So diagnosis of these hypersensitivities really requires detailed patient histories where you've kept track of what you're exposed to and when you have these types of reactions to identify what the allergen is. You can also go through what's called a pick puncture skin test, or a PPST, which is what we see in the image here. This is usually either done on the arms like we see or on the back. And what happens is they actually stick different antigens, you can see along the arm where each one of the sticks was made, and they look to see if you have what's called a wheal and flare reaction. The wheal is the swelling, and then the flare is the redness that develops. If you have one of these types of reactions, that's telling you that that's something you are allergic to. Your immune system is responding to it. Treatments for types of these things typically involve drugs, so either antihistamines to control the histamine that mast cells are producing, anti-inflammatory drugs like corticosteroids to control the inflammation, or if you have severe anaphylaxis, then epinephrine, which is really controlling the anaphylaxis and not really the immune system response. There's also things called desensitization therapy, where you can actually expose the body, so either through injections of tiny amounts of the allergen. What this does is it causes the body to produce IgG against that allergen, with the hope that then when you see it, okay, so here's your allergen, you now have a bunch of IgG that can bind it and block it from binding to those mast cells that, remember, that had the IgE on the surface. So if you stop that interaction, now you're protected. You won't actually have an allergic reaction anymore. The last thing we're going to look at where the immune system is doing something you don't really want it to is organ transplant rejection. So if you have a donor that's going to be donating an organ to someone else, you have to make sure that those donor and recipient organs have similar MHC molecules. Remember, the T cell receptors are supposed to bind to MHC if it's presenting foreign antigen. If it's presenting self-antigen, this doesn't induce binding. And so as a refresher, remember all of your nucleated body cells have MHC1 on the surface. So here's your MHC1 molecules. And say this here is your recipient. Okay, so this is what all of the cells in the recipient look like. The organ that's coming from the donor, however, might have MHC1 on the surface that looks slightly different because the genes for the MHC have mutations in them. Your MHC molecules do not look exactly the same as someone next to you. And what can happen is that the cytotoxic T cells of the recipient might have a T cell receptor that actually recognizes and binds to that MHC1 molecule, even though it's not presenting foreign antigen. So it's not presenting anything foreign, there's nothing wrong inside that cell, but the MHC molecule itself looks different enough that to the cytotoxic T cell, it looks like it's presenting something foreign. When cytotoxic T cells become activated, where they release perforin and molecules that will kill our own body cells, and so in this case, the cytotoxic T cells of the recipient are killing and attacking the organ from the donor that we just put in. This is why you have to try to match those MHC between your donor and your recipient as close as you can so that the recipient's own immune system doesn't attack the organ. We actually make sure that people take immunosuppressants even if they are close matches just to try to prevent this from happening. I also want to note this isn't required for blood transfusions, where we talked about hypersensitivity reactions that could happen if the carbohydrates on your red blood cells don't match, but you only have MHC1 on nucleated body cells, and red blood cells don't have a nucleus, so there is no MHC1 on their surface and you don't have to worry about those matching. That's lucky for us because it makes blood transfusions much simpler than something like an organ transplant.